Thanks for hanging with me. It's Chapter 42, Antifungal Drugs. This is our last audio lecture of the semester. Wow, can you believe that? Don't stop now. Let's talk about these antifungals. So fungi are very large and diverse groups of microorganisms, including yeast and molds. When compared with bacteria, the fungi have a more rigid cell wall, and the cell membrane contains ergosterol. So they often cause chronic infections, and they're resistant to all antibiotics. Fungal infections are called mycoses, and they could be superficial, subcutaneous, or systemic, because many of the fungi are part of the normal flora of the skin, the mouth, the intestines, and the vagina. So they're normal, but they can become an opportunistic infection or an opportunistic pathogen. The occurrence of systemic mycoses are usually the most difficult to treat and the most life-threatening. And that is because they are there when their patient is immunocompromised, like those with cancer or HIV, those who've had organ transplants. So in the hospital, you may see some of the complicated surgical procedures like the use of implanted devices. And because of that, we've had this administration of these broad spectrum antibiotics, and that dramatically increases the incidence of these healthcare related or the healthcare acquired infections, what we used to call nosocomial. Our most notable opportunistic fungal pathogens include Candida albicans and the non-albicans Candida, Aspergillus, Cryptococcus, and the Zygomycetes species. So let's talk about these yeast. They're single cell, and they reproduced, or single cell fungi, they reproduce by budding. Now, ironically, we use these for baking, right? We use these in alcoholic beverages. And these are the yeast infections that we see superficially. We see these on the skin, and we may see them like in our tinea corporis, our tinea cruris, dermatophytosis of the feet or the hands. And so they're easily diagnosed just based on the location and the characteristics of them. Again, we will see yeast infections in the vaginal vault, so women suffer from those. And these are treated pretty quickly and pretty rapidly. Our molds then are multicellular. These are characterized by long branching filaments called hyphae, and we can see that when we look at them underneath the microscope. But our mycotic infections then fall into these four general types, those cutaneous or subcutaneous, then superficial, and the systemic. Now, the systemic can be life-threatening, and typically we only see those in the immunocompromised host. Let's talk about a couple of those. Our mycotic infections. The Candida albicans, we see this often with antibiotic therapy if we've given antineoplastics or any type of immunosuppressants. When we have these drugs being given, remember the fungi are resistant to the antibiotics. So we get an overgrowth of this, and we can have a systemic infection. We will see this in the mouth. It's called thrush or oral candidiasis, and it is common in newborn infants. It's also common in immunocompromised patients. The vaginal candidiasis is a yeast infection. We'll see this in pregnancy. We'll see it in, that's because of, we'll talk about that more when we get to maternal health, but it's because we've just the whole process. And then with women with diabetes mellitus, women taking oral contraceptives or following a round of antibiotics. So the antifungal drugs are used to treat these infections. We can have topical or systemic. Now the systemic, we have things like amphotericin B, cospofungin, fluconazole. Many of you probably have heard of that. Topically, you've probably heard of the nystatin. There are other drugs out there. But they are broken down into major groups based on their chemical structure. And I'll talk about those very quickly, but we may go into yet one last section on this antifungal group. So the major groups, their chemical structure, we have the polyenes. This includes our amphotericin B and nystatin. And the way they work is they bind to the membrane of the ergosterol. And so it alters that membrane's integrity. The immunosoles, you probably recognize ketoconazole. Those inhibit the cytochrome P450 and thereby affect the cell membrane. The triazoles, that's our fluconazole, itraconazole, voriconazole, these inhibit the cytochrome P450 and they demethylase it. So that blocks then the synthesis of the ergosterol. So then the membrane can't be maintained and it can't regrow or develop. The echinocandins, cospofungin, micafungin, those are non-competitive inhibitors of the 1,3-beta glycan synthase, and that's the enzyme that's responsible for the formation of an essential cell wall component in many of these pathogenic fungi. We will actually see the echinocandins used more frequently in the treatment of pneumocystis carinii cyst because it has good activity against that, as well as Aspergillus, Candida, and histoplasmosis or histoplasmia. So it is actually, these drugs, the echinocandins, are actually used more in the treatment of refractive infections. Now, we have a couple that are listed individually and not by chemical structure, and that's griseofulvin. And what it does is it inhibits fungal mitosis by binding to the intracellular microtubular proteins. Our flucytosine is frequently you'll hear it called 5-FU, and it is known as 5-FU or 5-fluorocytosine. It is an antimetabolite, and it's converted to 5-fluorouracil once it is in the system. So that is then incorporated into the fungal RNA. So they've taken up by these fungal cells and incorporated, and it inhibits protein synthesis. So the result ultimately is fungal cell death. It is an older drug. Newer drugs are more commonly used, but I think that we're starting to see actually a comeback of the 5-FU. And so that's not necessarily a bad thing. With our griseofulvin, this disrupts the cell division, as I said, and it too is an older drug. With our polyenes, this is amphotericin B and nystatin. So these are, they bind to that ergosterol in the fungal plasma membrane, and they interfere with that lining. So fungal cell death occurs. It does not bind to the human cell membranes or kill human cells. That's a plus. Our immunosoles and triazoles, we see these as all ending in the azole, right? They affect that P450 enzyme. So we want to make sure that we're looking at other drugs that might be interacting with that based on their function. We have ultimately altered cell metabolism and fungal cell death. We talked about the echinocandins and how they prevent the synthesis of the glucans, resulting in fungal cell death. So all of these drugs are indicated for systemic and topical fungal infections. The drug of choice for the treatment of many of these is based on the severity So our amphotericin B is the one that we choose when we have a severe fungal infection. And that's because this drug is active against most species, including Cryptococcus neoformans, Candida albicans, Sporotrichum, Blastomyces dermatids, Histoplasma capsulatum, Coccidioides, and the Aspergillus fumigatus. When we look at these, we have a thing called, sometimes you'll hear it referred to as amphoterrible because of the side effects of the amphotericin B. So it has that nickname because the effects can be pretty serious. A major adverse effect is renal impairment, and it's reduced by previous sodium overloading, but we can have cardiac dysrhythmias, neurotoxicities, including tinnitus, visual disturbances. In the hands and feet, we'll see paresthesias or numbness, tingling, pain. They maybe have convulsions. Potassium is lost, so we'll get hypopotassium, we'll get hypokalemia, also hypomagnesemia. Pulmonary infiltrates can occur. Thrombophlebitis can occur. Fever, chills, headache, nausea, occasional hypotension, and GI upset or anemia. So lipid-based formulations sometimes limit the exposure of the human cells to the drug, and so they're less toxic, but they're much more costly, and they are not interchangeable. So if you hear of amphoterrible, you'll know that they're talking about amphotericin B. With our other drugs, the adverse effects of the fluconazole usually include nausea, vomiting, diarrhea, maybe some stomach pain. We'll see increased liver enzymes. We want to use these in caution with patients that have renal or liver dysfunction. Nystatin, sometimes nausea, vomiting, anorexia, diarrhea, and rash. And we'll see these vary a lot less if we're using a topical form of that. Our antifungal contraindications include liver failure, renal failure, porphyria, particularly if we're giving griseofulvin. And porphyria is a group of disorders that can cause nerve or skin problems because there's an accumulation of this thing called porphyrin, which is a component that helps hemoglobin. Obviously, these drugs are contraindicated if we have a drug allergy. Many of them are metabolized by the P450 enzyme system, like I said before. So co-administration of two drugs that are metabolized by this system can result in competition for the enzymes. And so we get higher level of one of these drugs, so we can see toxicities. Our nursing implications before beginning therapy, we want to assess for hypersensitivity, possible contraindications, and any conditions that require cautious use. We're going to get baseline vital signs, CBC, liver, renal function, and an EKG. Remember, we sometimes, particularly with amphotericin B, we want that EKG or ECG. We assess for other medications that are used to avoid the interactions, particularly those that might conflict with that P450 problem. We want to make sure that you're following manufacturer's directions carefully if you're reconstituting and administering these drugs. And we typically monitor vital signs if these patients, if they're getting an IV infusion every 15 to 30 minutes. During the IV infusion, we also monitor INO because we're looking at renal problems, right? With our amphotericin B, we want to reduce the severity of the infusion-related reactions. And so sometimes we'll give pre-treatment with an antipyretic like the acetaminophen. Don't want to give a NSAID in this example. And so I'm going to leave that to you to look up. Why would we not want to give ibuprofen? Why would we give acetaminophen? We may give an antihistamine, an antiemetic, or a corticosteroid in addition to reduce the severity of infusion-related reactions. So we're going to use a pump on these and the most distal vein possible. We're going to have to move on to one last little short lecture. Bye.